Welcome to the webinar. We're focusing on maternal depression and the intersection with infant and early childhood mental health consultation. This webinar is being sponsored by the Center of Excellence in Infant and Early Childhood Mental Health Consultation. The Center of Excellence was established by SAMHSA, the Substance Abuse and Mental Health Services Administration, in 2015 to increase awareness, adoption, and broad-based implementation of infant and early childhood mental health consultation. As many of you know, mental health consultation is a service that pairs a mental health consultant with families and adults who work with infants and young children in different settings where they learn, grow, and play, such as childcare, preschool, and home visiting. We're going to start with a very brief overview of why this is such an important topic for mental health consultants. And we're really going to spend the majority of the time on objectives 2 and 3, really learning about an innovative and comprehensive model of infant and early childhood mental health consultation called Family Connections. Kathy Ayoub is one of our presenters today. Kathy is an associate professor at the Harvard Medical School and one of the founders of the Family Connections Infant and Early Childhood Mental Health Consultation Model. In addition to being a mental health consultant herself for many years in early care and education, home visiting, and healthcare organizations, Kathy is trained as a psychologist and a nurse practitioner, and she's written more than 100 peer-reviewed articles, book chapters, and I think for today's purposes, many translational papers on the intersection of infant and early childhood mental health consultation and caregiver depression. We're thrilled also to have Deborah Sosin, who serves as the Director of Family Connections, with us today. She has had a career of over 40 years, serving both as a mental health consultant herself, a clinical practitioner, and an educator. I am Deborah Perry. I am very pleased to be part of the Center of Excellence team, and in my own research life, I have done a lot of work on perinatal depression prevention. And so I have the great honor and privilege of being the mistress of ceremonies for today's webinar. Just a little bit of background on the rationale for our focus on depression. I think many of you know that depression is both a very highly treatable, serious mental illness. It's one of the mental illnesses that we have the highest rates, lots of good, effective, evidence-based treatments for, including psychopharmacology and psychotherapy. It's also a very serious mental condition that has high levels of comorbidity, especially comorbid with anxiety and substance use disorder. And so it's really a high priority of SAMHSA. We also know that with increased depression comes a high risk of suicide. Today, we're focusing on depression in mothers with young children, in part because the pregnancy and postpartum period is a time of increased vulnerability for many women for the first onset of depression, but it's also an incredible opportunity to intervene with moms and on behalf of both the mothers and other family members, including those babies and toddlers. As you all know, home visiting programs in all states, territories, and tribes serve pregnant women and moms into the postpartum period, and most infants, toddlers, and preschoolers at some point in their lives are in early care and education, whether it's childcare, family childcare, preschool, etc. And now, with more and more mental health consultants working in these settings across the country, there is a growing need to have strategies to address maternal depression in the mothers served in these programs. As I mentioned, it's a very highly prevalent condition. About 1 in 7 women overall present with depression during the perinatal period, so pregnancy and the first year postpartum. But the rates of depression in pregnancy and the first year postpartum are much higher for lower income women of color, anywhere from 30 to 50%. For example, more than half of the mothers in early Head Start national research study reported clinically significant levels of depression, and Kathy and Debbie will attest to the fact that that was one of the things that motivated them to develop this sort of specialized mental health consultation model. We also know from lots of decades of research that depression has long-lasting effects on social, emotional, and behavioral health in young children. Many of you are familiar with the Adverse Childhood Experiences Study, the ACEs study, and so many of you will recognize that parental mental illness is one of those 10 adverse childhood experiences. Long-term impacts not only in substance use later in adult life and also risk for mental illness in children who have high ACEs scores, but other chronic health conditions. So really a long-term reach. We also know through Jack Schoenkauf's incredible research through the Harvard Center on the Developing Child about toxic stress and how exposure to toxic stress, if not mitigated by the presence of a buffering adult, can lead to actual physical changes in early brain development that also have long-lasting effects. I think we definitely see the need for mental health consultants increasingly who are working in home visiting and early care and education settings to have strategies that they can use to help mitigate the negative effects of maternal depression on young children and the families that they're serving. With that, I'm going to turn it over to Kathy to get started.
Thank you, Deb. Hello, everybody. It's really a pleasure to be here today. Deb Sawson and I are going to talk a little bit about Family Connections as the infant and early childhood mental health consultation model that has one focus on depression and resilience. And the first thing is to say that we always couple the two. So you'll see us talk about depression along with resilience. Let me start by talking about the context in which, as mental health consultants using the Family Connections model, we have really thought about working on issues that are related to depression with staff, with families, and with children. First of all, Family Connections is a system-wide, comprehensive, preventive, strength-based, and embedded mental health consultation program. And what this really means is that when you're going to talk about a sensitive topic like depression, for us it was really important to have the mental health consultant embedded, to be part of the staff, to be involved with the home visitors, to be involved in the early care program, and to be available on a weekly basis. We wanted to set that context for you so that you really have a sense that the mental health consultants that we're talking about are really in there as part of the program team. And we really are talking about early care professionals and home visitors, both what the mental health consultant can do, both with home visitors and working in homes as well as in center-based kinds of settings. And again, as I said, there was a core component of our mental health consultation work that really addressed depression and resilience. And I want to make sure that here I acknowledge my colleague, William Beardsley. Dr. Beardsley really is an ongoing expert in thinking about depression in families, and he really wrote a very popular book about depression in families. And it was because of that book that he was approached by some folks from one of the regional Head Start offices and asked what could he do in working with young children and families. And I was really pleased that he came and found me and said, gee, tell me what you know about young children and mental health consultation. Is this a vehicle for talking about depression? So our constructs really have to do with looking at depression and resilience and addressing staff, families, and children, and really talking about depression as adult depression.
And I also am so delighted to be here with all of you today. And I'm so pleased that you're interested in learning more about working with families that might be facing depression. So Kathy shared a bit about Family Connections, and we have 3 primary foundational principles that we think about with both professionals, staff, home visitors, teachers, and also parents. And those are self-reflection, self-care, and perspective-taking. And all three of these constructs also support resiliency, which is so critical to think about in terms of depression and folks that are facing other adversities.
Okay. We're going to start actually at the back end to tell you a little bit about some of our lessons learned in talking about depression as mental health consultants and working in programs. So I'm going to just go through the list. First of all, and I think I said this before, depression impacts all adults. So we found that instead of beginning to work with staff around family members who experience depression, particularly with the focus on those new moms or moms who were pregnant who appeared to be depressed, because we know that's the highest risk period, we realized that this is such a common mental health concern that we really needed to talk about all adults, because almost everyone has either had an experience of depression or knows someone who's been depressed. Secondly, I mentioned this before, but embedded mental health consultants with knowledge about depression and really having some tools to work on issues of depression with staff and families and children are the most effective. The third issue really here is that commitment to addressing depression and resilience really means that everyone in a program needs to be involved. So talking to teachers or home visitors without including leadership, thinking about talking to staff without thinking about how this is going to apply to families and children, and keeping issues around depression in mind when we're in classrooms working with children or we're doing workshops with families. We need to think about addressing depression and resilience across all of those venues. This fourth issue really should be in big capital letters. Building relationship with staff is the first step, the most important step. And Debbie's going to be telling you a little bit about how we do that in terms of a workshop. Then depression and resilience really present with different cultural variations and stigmas. And I know that you all know this, but this is so important to consider. We've had the great honor of being able here at the Browson Center to work with a number of tribal communities. And we know that each tribal community really may have their own values and traditions and beliefs, and it's very important to understand those. I also come from a Hispanic background, and I know that the way that depression is understood in Hispanic communities is very different, and it may vary from country to country. I happen to have grown up in Mexico, and I know that the Mexican families with whom I work have particular ways of understanding depression, and for example, it's really gender specific. Many of the women with whom I've worked have special ways of describing depression as having an attack of nerves or an ataque de nervios, whereas that's not something that a Hispanic man generally might say. Now, again, I'm overgeneralizing. However, I want you to get a sense of how important it is to understand the cultural variations, and that really also leads to differential stigmas about having a mental illness, particularly depression. Finally here, do no harm. As mental health consultants, we need to make sure that when we're talking about issues as sensitive as depression, that we not only are helping folks identify depression, but putting in place the kinds of checks and balances and processes we need to really be able to support people through treatment. The more things, as I said before, program leadership involvement is essential, and capacity building includes staff of all roles. We often suggest in our workshops that the director of the program be there, as well as the direct line staff, as well as in a center-based program, the receptionist or the cook or the bus driver. And it's really important that all of the staff actually serve as support to each other as they talk about these sensitive issues, but also that there is a general understanding of people's perspectives. Ongoing reflective supervision really enhances staff capacity, critically important. Increasing the capacity of providers to address mental health concerns, we know not only helps them to better manage and to work with families, but it also improves the climate of the entire program and the quality of care. So this is something that we found in some of our research around considering and presenting issues around depression within the Family Connections model. Addressing depression may include a number of different activities. screening, further assessment beyond screening, crisis intervention, support, referral, and follow-up. And all of these are very important kinds of activities for the mental health consultant. And the mental health consultant is really uniquely positioned often to be able to support screening, to be able to help with further assessment to determine what kinds of risks may be present and what kind of referrals or supports families need. Crisis intervention is often critical, particularly when we see families and we see adults who are really severely depressed, where we may be worried about things like suicide or harm to others. Support, of course, referral, and Debbie's going to be showing you some information about really thinking about what kind of treatment do we think about for depression, what does referral mean, and always follow up. Finally, to just point out that talking about sensitive topics like depression can be stressful and it takes time. So coming in as a mental health consultant and doing a single workshop or talking to a single group of people is really not enough. You really need a comprehensive program. With that, I'm going to start to tell you a little bit about how we do it. The first thing we wanted to mention here is that we have a set of what we call professional development modules for staff within the Family Connections model. And a number of these modules are really developed to help us talk about depression. And as you can see, if you take a look at the third topic in Module 1, it's a workshop called What is Depression? We actually set up these workshops. Mental health professionals can deliver them to staff in any order. However, we ordered them in a way that really balanced talking about difficult topics like depression with talking about positive topics and more universal topics. Because frankly, when we piloted these workshops in Head Start and Early Head Start programs, the staff said to us, don't talk about all those depressing things at once. We know you're savvy mental health professionals, and we need to learn from you, but talk to us about things like promoting positive behavior, engaging parents, as well as talking about depression. And we did choose to talk about adult depression first before we talked about impacts on children. With that, I'm going to turn this over to Debbie and have her say a little bit more about the modules, particularly the one we're going to share with you today.
So Kathy has already given you some background to the Family Connections approach. There are a number of articles that are part of the Family Connections materials on the Brazelton Touchpoint Center site. The materials were written through an Office of Head Start Innovation grant. They are all in the public domain and can be accessed, again, at the Brazelton Touchpoint Center site and also at the ECLIP site, the Head Start site. So we hope that you will access them. And the modules, as Kathy said, do build upon each other, and we have found one important piece of the module is that we really use an adult learning approach and style. We want to be sharing information with people, but we've also learned that information alone, knowledge alone, is not sufficient for change and action. So we really do try to tie each of the modules into people's personal experiences and always start with an interactive exercise that helps people to begin to think about and make meaning of the particular topic and issue that we're addressing. So what we hoped to do today was to share with you one of the workshops. What I'd like to do is share with you a little bit about how we set up this particular activity. Again, to begin by saying, as Kathy stated, that we never begin with the What is Depression workshop for many reasons. I think the first and foremost is for the workshop to be most effective, participants need to be able to share and need to be able to honestly express worries and concerns and thoughts. And before going further, I would like to take a moment to just express my thanks and gratitude for the participants, both professionals and parents in the Boston area and throughout the country who have gone through this workshop with us and have shared their thoughts. So the workshop begins with 6 large Post-its around the room with these 6 interactive questions that look at depression. And our goal here is not meant to teach professionals who are not therapists to be therapists. It's really meant to provide information that will be useful for home visitors, for teachers, for directors, to be able to reach out more effectively to parents who might be struggling with depression. Through these questions, we're asking people to think about, where does depression come from? What does depression look like? That might include thoughts, feelings, behaviors, and physical symptoms. And also, what are the common attitudes and beliefs around depression? We know that throughout Family Connections, and for all of us in our role as mental health consultation, that cultural awareness is imperative to the work that we do. And knowing that we all view the world through our own cultural lens makes it very important for us to be thinking about how depression manifests in different cultures and what stigma is related to depression, or more generally to the topic of mental health in different cultures. One of the things that we've discovered in doing this particular workshop is that people hear mental health and the first thought that they have is mental illness. And mental health, as we know, and depression is on a continuum. So we're wanting folks to be thinking about that as well. So let's pretend that you're in a room with maybe just 25 colleagues or parents, and there are Post-its around the room, and there's one that says, where does depression come from? And the responses that we have are some that we've heard from participants that they've shared throughout the country. We've done Family Connections in urban, rural, and tribal communities, and oftentimes people respond nowhere. I think that this particular workshop is also a needs assessment for the mental health consultant and the work that they're doing in a center with home visitors in terms of where people might benefit from further knowledge and understanding about depression. As we go through this exercise, the way that the workshop proceeds is that the participants go to all 6 of the questions and respond and answer them. And then we join back together as a group and process the responses. And in the context of processing the responses, the mental health consultant also has the opportunity to share some additional information, to try to clarify information, to wonder as we do so well and question some information. And certainly another response that I'd like to speak to is racism, oppression, and social injustice. And when we first started doing this exercise many years ago, that was not one that showed up as frequently. And in the last number of years, we're seeing that more and more often. And knowing that depression may be an absolutely normal and appropriate response to many of the adversities people face that are living exposed to racism and social injustice. I also just wanted to comment that separation from support was very high, and when we think of so many of the families that have immigrated from this country and have left families behind, and also verbal, physical, and sexual abuse. So those early traumatic experiences, or not so early experiences. So we'll go on to one of the next questions. What are some common attitudes and beliefs about depression? So these are responses that we've gotten, again, from people all over the country. And we ask participants not only to share their own attitudes and beliefs, but also to add what they've heard. We want to give people the opportunity to share their own thoughts, and in a way that won't be embarrassing to them. And we also want to begin to address some of the stigma and the stereotypes surrounding depression. These are some common ones that people have shared. Depressed people are weak, are crazy, it's all their own fault, it's just laziness, they could just snap out of it, the spirits are causing it, and that there's nothing that I can do to help a person with depression, and prevention doesn't work. It's impossible to prevent depression. This question is the one that we receive the most profound answers for. And this question is, what is your biggest fear around someone who is depressed? And people usually start with things like that the people won't seek treatment, but very quickly participants move into the person thinking about hurting themselves, or more seriously, the person thinking about ending their life by suicide. And with this particular question, people often share their own experiences with family members or perhaps their own experiences with depression. And since we know that 1 in 5 adults will experience a serious depression during the course of their lifetime, everyone in the room more than likely has been touched by someone who has experienced a serious depression. And this gives us the opportunity to both think about and support people who might be facing depression, and acknowledging that these fears are fears that we all might have, and that there might be ways to help and support people. I often think about when people are depressed that they may have tremendous difficulty making decisions, and how many decisions does a parent of a young child need to make in every hour, in every minute? The decisions are fast and furious, and if a parent is struggling with depression, it certainly can impact them. Also, I know we've got low energy and lots of others.
Yeah, this list really seems to capture a lot of the important mechanisms through which we think depression may lead to some of those negative effects on children. It's really through changes in parenting that we think some of those more profound changes may happen, right?
Absolutely. And clearly, most all of these are of concern for those of us that are working with parents. But we'll talk a little bit further along about parenting and how we can support parents. So again, it looks like the decreased ability to accurately interpret and respond to a baby's cues and meet their needs is the one that most people responded to. So the last slide that we would move to would be, how is depression treated? Again, we have a list here of the range of responses that we've heard. And one thing that we do know and are aware of throughout the country is that there are limited resources in many parts of the country, in many urban areas, rural areas, and tribal areas. Not everyone has insurance or has access to insurance. And we do know that a larger percentage of women who struggle with depression do not receive services. So one of the questions that we think about when we do this particular exercise with people, we know that depression is one of the most treatable mental health related issues, and that psychotherapy and medication, group therapy, family therapy, all can be very effective treatment modalities. We also know that there's some adjunct treatments or supports that can really make a difference in a person's well-being. And so we often see exercise, self-care, but we also hear frequently in the work that we're doing in Indigenous communities is that there are many Indigenous healing practices that really need to be honored and used as well for people, because culture plays such an important role in how people perceive depression. Spirituality and religion is one that's been added across the board, whether we're urban, rural, or in tribal communities. So these are the different ways that people have spoken and have thought about. And sometimes people have talked about substances or people who self-medicate. And that gives the opportunity for the mental health consultant really, again, to explore that, to talk about comorbidity, and to think about, together with the group, what possibilities there are to support people with depression. And so after the group, if we've been doing this together as a workshop, we've processed all of these together, we do shift to resilience and talk about how we can foster resilience for families and for ourselves. Self-care, as I mentioned earlier, is a critical piece of the work when we're doing family connections at sites as mental health consultants, and when we're doing training around implementing family connections and how we can support the self-care providers and family members, and of course the social and emotional well-being of children. So I'm now going to turn this over to Kathy, and she's going to talk a bit more about working with providers.
Thank you, Debbie. As you all have seen, we just wanted to give you a sample of some of the ways that we actually can partner with staff or with parents to present a more formal workshop on depression. And there is both our short papers, say 2 for staff, I think, and 1 for parents, about depression and parenting and resilience. And also there is the workshop that Debbie just talked to you about. So you can download those anytime. So I'm going to spend a few minutes talking a little bit more about how, as mental health consultants, we can work with providers and then families and children around issues that relate to depression. So again, a couple of principles. As mental health consultants, we really have to make opportunities, but there are lots of them that are there for us. First of all, there are many programs that really either voluntarily or have some requirements around screening. We know that a number of the McV programs really have as one of their benchmarks to really examine screening for depression and to address depression. In Head Start and Early Head Start, but particularly in Early Head Start, oftentimes there is a strong mandate to think about screening, particularly prenatal and immediately postpartum, for symptoms of maternal depression. So screening in a number of cases has been built into the systems. We also know that in Head Start and Early Head Start, there actually is a mandate through the standards to provide mental health consultation. So you put the two together, and working with staff can really be critical for the mental health consultant in terms of moving forward both their capacity to really understand, to identify, and to respond to adult depression. I mentioned screening, but I think we go beyond routine screening. There is support. There's classroom or home visiting observations. There's connections with teachers, with home visitors, with family service folks, formal workshops like the one that we just told you about, and regular consultation on issues that have to do with individual families. So let me move and give you some examples. Several of you wanted to know, so what do we say to a mom with a newborn or a pregnant woman who appears to be depressed? And one of the things that is the most helpful and simple question oftentimes is just to say, how are you feeling? Open up the question and be ready to listen. Being available to listen and using your diagnostic skills are the critical skills and practices that we each have as mental health consultants. So those can really be helpful. And then we can't open up that question without being knowledgeable about the options for evaluation and treatment in our own communities. And as Debbie said, there may be a number of them. Some communities may have richer options than others. But there are so many ways to really address depression that it really may be about finding some of those and helping staff really have the capacity. Let me give you a quick example. I've had the honor of working with a number of communities that are doing home-based work, I think both through Early Head Start and through home visiting and tribal home visiting programs. And we've found in a number of communities, and our tribal partners have talked about this, when there have been screening instruments that have been used, the rate of depression is really high. And the question then for the home visitors, they come back and they say, what do we do? And how do we understand these screening measures? And that's a wonderful opportunity for mental health consultants to work with home visitors, to sit down with them, to look at the kind of findings that they have on a screening tool, to talk to the home visitors and really try to understand, what did you see when you were there? What did you observe? What did the mother say? What did she do? How did she appear to you? And to use our diagnostic knowledge and skills, not to make a diagnosis because we're not treating, but to be consultants, to use the array of diagnostic skills that we have, particularly around depression, to be able to help staff to differentiate and to really assess risk so that they can determine where they may want to go next with a particular family. Let me go on and say a little bit about what about parents. again, you'll see that a lot of these principles are the same. It's about making opportunities as mental health consultants. Again, we talked about using routine screening through staff. There may be an occasion where we're having an informal conversation with a parent. It's happened to me more than once in a hallway right after drop-off. And the parent says something to me, and I'll say to them, "How are you feeling?" Or they'll even say, "I feel depressed." So pick up and drop off are amazing times to be in classrooms, to connect with parents. I even have had the honor of going on home visits with home visitors and then talking to them on a regular basis, providing regular consultation for staff, and then having them actually say, "We'd like for you to also be with us as you talk to this parent." Sometimes I'll model for staff in my conversations with parents. When parents come together for socialization, but again, it's about listening and using your diagnostic skills. Let me give you some examples here. In thinking about parents, the one example that I think of that's so powerful, I worked with several early Head Start programs. They provided both home-based and center-based services. And the home visitors were very concerned about how many depressed moms they saw beginning in the third trimester of pregnancy and then through the postpartum period. And they really were so concerned that they actually developed some linkages with their communities, and the Early Head Start program got involved with a treatment program with mental health treatment providers who came into the home and provided time-limited, what they called relational and behavioral therapy for moms. So the job of the home visitors was to go in, spend time with the moms, get to know them well, get some sense of how they were feeling, do a screening assessment, and get a good sense of, gee, might this mom be at risk for depression, or are we finding some evidence of clinical depression on the screener, and having preliminary conversations with that mom, coming back and consulting with the mental health consultant, talking to her, and then bringing this third party in, bringing in the mental health treatment provider from the mental health center, and the three of them talking about whether or not this mom might be a candidate for mental health depression services. Then, as you might imagine, supporting the home visitor, the mental health consultant helped the home visitor really talk to the mom about how would you like this service? How would you like for someone to come into your home and talk to you about depression and ways that you might really be able to feel better and to continue to be a good parent? One of the things, by the way, and I learned this from Dr. Beardsley, is that oftentimes being a parent can motivate an adult to really consider their depression, to do something about their depression, and to begin to take that first step, which often is so difficult when adults at postpartum moms are really feeling very lethargic, feeling sad, feeling unable to really feel energetic. So the notion that being attached to your beautiful young baby is a tool that you can use to motivate parents to really seek support for their depression is a good thing to remember. And that's one of the primary constructs that in this three-way kind of work between the depression treatment professional, the home visitor, or the center-based teacher, and the mental health consultant. They together present this to the mother, and there really were tremendous results after a 9 to 12 week set of sessions by the treatment provider in the home with the mother. There were times when the treatment provider would invite the mental health consultant to come join the end of a session and relay the information. And in the last session of treatment, oftentimes the home visitor always, and sometimes the mental health consultant, would join so that there would be a debrief between the mother and the three professionals, and the home visitor could continue to do her work in the community. Again, just to share with you, this is a statement from a flyer that Drs. Beardsley and Jacob developed, and this is really what they want a new parent who is depressed to attest to. Can a depressed parent be a good parent? You bet. Yes, you can. And to really use that as a positive motivator. I'm turning this back over to Debbie so that she can talk to you about working with children.
Absolutely. So as we know with family connections and with most mental health consultation models, that working systemically, working with the providers to support capacity, working with families and working with children while not doing direct treatment, is certainly one approach to mental health consultation. So thinking about the work with children, they're the same principles that Kathy mentioned, that they're really those opportunities that we find to support providers, home visitors, teachers in terms of their work with kids and being in a classroom with children. And the role of the mental health consultant is clearly very different than the role of the mental health therapist, which Kathy spoke to. It's important for the consultant to have a deep knowledge of child development, of trauma, of the impact of depression on young children, and how best to support and scaffold all parties involved. The strategy that we use in Family Connections is the Tell Me a Story series, and those are available also online at the places that we spoke about. And the Tell Me a Story is an intervention that supports children's ability to talk about different topics. And it's really designed to help children understand and describe their emotions. And it's also, the modules that go along with it are there to help teachers and parents and home visitors speak with children and have those difficult conversations. One of the books that we developed specifically for Family Connections and Tell Me a Story is called When My Mom is Sad. And it really talks about depression through the eyes of a preschooler. And it provides some age-appropriate knowledge, understanding, and also some resourcefulness. And in reading this together with the children and the providers, we may ask questions like, what makes you sad? What helps you to feel better? What helps mommy to feel better? And often as we read these books, many of the children, the preschoolers and some of the toddlers share their experience, and oftentimes they cry and then end on hope and resilience. So one of the last things I wanted to highlight is that the mental health consultant really operates on multiple levels at all times. One of the things that we do in this model is debrief with the teachers after we've read one of the Tell Me a Story books. And in the debrief with these teachers that I had known for probably 3 or 4 months, I asked the teachers, so what did you think? How did you feel? And one of the teachers said, I'm depressed. And that opened up a conversation and the ability to explore with that teacher and scaffold and help her get some of the resources that she needed. So in closing, as mental health consultants and as mental health clinicians, we like to think that it's easier to build strong children than to repair broken adults. But we also hold hope and know that depression is highly treatable and that the work that we do as mental health consultants in early care settings and in home visiting programs helps support those healthy and strong children. Well, I'll turn it over now to Deb.
Thanks so much. I really appreciate it. I also just wanted to say thank you so much for all of you participating. We appreciate all of your interest in this work, and we will continue to get resources and opportunities for you to grow your own practice for states, tribes, and communities. Thank you so much, everybody.